You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about QT prolongation. We'll go over fundamentals about the QT interval and how it is defined. We'll talk about QTC formulas, including Bazzett's formula, Friederich's, Hodges, Routharju's, and Framingham's formula. Then we'll talk about the long QT syndromes and management of long QT syndromes. We'll go over acquired long QT conditions, and then we'll end with a special section on short QT syndrome. Let's start with the QT interval. The QT interval represents the time taken for both ventricular depolarization and ventricular repolarization. It begins at the start of the Q wave and ends at the T wave. If there's no Q wave, then you start measuring it at the R wave, the start of the R wave, and then still end it at the end of the T wave. If the QT interval is less than half the RR interval, you can be sure that the QTC will be less than 460 milliseconds. The QT interval is heart rate dependent and is typically corrected for heart rate variations. That's your QTC. QTC will be underestimated at low heart rates, less than 50 beats per minute, and overestimated at high heart rates, more than 100 beats per minute. For the purposes of the board exam, use 400 milliseconds as the normal QT interval for a heart rate of 70. For every 10 beats per minute change in heart rate above 70, subtract 20 milliseconds. For every 10 beats per minute heart rate change below 70, add 20 milliseconds. And the final measured value should be within plus or minus 40 milliseconds of the calculated normal. For example, in a patient with a heart rate of about 100 beats per minute, the calculated normal QT interval is 400 minus 3 times 20 milliseconds. So 400 minus 60, that gets you 340. So you'll need to be within 40 of that. So 300 to 380 milliseconds is the range that you can be in for the QTC. The definition of prolonged QTC is 450 seconds for males and 460 milliseconds for females or more. But if that is the only thing that they have, meaning it's just an incidental ECG finding with no syncope, no family history, no arrhythmia, etc., then there is a less than 1% positive predictive value for long QT syndrome, so it is more practical to use thresholds of 500 milliseconds in practice. There are two situations where you expect QTC to be more than 500 milliseconds but still have a low risk of being torsarogenic. One is a patient with bundle branch block at baseline causing wide QRS. Another is patient being on amiodarone. Other than these two situations, you have to be concerned. If there is wide QRS, it is almost certainly not a congenital long QT syndrome, although it could still be drug-induced long QT syndrome. In wide QRS scenarios, such as pace rhythm or bundle branch block, then you can just make a wide QRS adjustment. The QTC adjusted is just the QTC minus, all in brackets, QRS minus 120 milliseconds. That's how you make a wide QRS adjustment. Now let's go over the common QTC formulas for correction of QT by heart rate. The most common one by far is Bazzett's formula. It's just QT divided by square root of the RR. RR is the interval between two consecutive R waves on the ECG. This is simple to calculate. However, it overestimates QTC at high heart rates and underestimates QTC at low heart rates. Please note that when you are calculating QTC, regardless of which formula you're talking about, the QT interval you're supposed to use is the number in milliseconds, and the RR interval you're supposed to use is the number in seconds. So for example, for a QT interval of 480 and an RR interval of 880, you're not supposed to do QTC equals 480 divided by square root 880. That's going to give you a number that's off the scales. You have to do QTC equals 480 divided by square root of 0.88. Next, we have Friederich's formula. That's QT divided by the Q root of RR. So that's just QT divided by RR to the power of 1/3. Hodges' formula is QT plus 1.75 times heart rate minus 60 in brackets. So the coefficient 1.75 is applied to the brackets heart rate after subtracting 60 from the heart rate. So that one provides more of a linear correction and it's a bit more accurate at the extremes since the extremes are not being cubed root or square rooted. Rata-Harju's formula is QT times in a fraction. The numerator of the fraction is 120 plus heart rate, and the denominator of the fraction is 180. Framingham formula is QT plus 0.154 times in brackets 1 minus RR. So it's similar in philosophy to Hodge's formula. You don't really need to know all of these. Just know that Baz's formula, which is QT over square root of RR, is the most commonly used, but it overcorrects at high heart rates. Friedericia's formula is better for use across a wide range of heart rates by a little bit more. Which lead should you use to measure QT? Lead 2 is preferred for QT measurement because it provides a clear view of the end of the T wave. You can cross-check in leads V5 and V6, which provide a good view of the T wave as well, especially when the morphology in lead 2 is unclear. However, this is not always the case, so the longest QT interval from any lead should be selected. Ideally, you should measure the QT interval across at least 3 consecutive cycles and then take the average to avoid beat-to-beat variability. Now that we've talked about the QT interval and the QT correction formulas, we can start to turn our attention to long QT syndromes. Long QT syndrome type 1, which is a mutation in the potassium channel leading to loss of function and thus delay in membrane repolarization, is the one that causes sudden cardiac death while swimming. Long QT1 is a loss of function in KCNQ1. Long QT2 is a loss of function mutation in KCNH2. Long QT3 is a gain of function mutation in SCN5A, which is also the channel mutated in Brugada syndrome. Brugada syndrome is a loss of function mutation in SCN5A. The T waves also differ across long QTs 1, 2, and 3. Long QT syndrome 1 has a broad T wave. Long QT syndrome 2 has a hump bump T wave. Long QT syndrome 3 has an isoelectric QT interval before the T wave. The triggers are also quite unique. Triggers from swimming or thrill from sports suggest long QT syndrome type 1. Noises and auditory triggers, especially during postpartum, suggest long QT syndrome type 2. There are no triggers that suggest long QT type 3 specifically. Genetic testing for suspected long QT syndrome is very good and has a sensitivity of 80%. The yield of genetic syndrome is 10 to 40% for Brugada syndrome, depending on whether there's prolonged PR, 60% for CPVT, and 75 to 80% for long QT syndrome. 25% of patients with long QT syndrome confirmed by a known genetic mutation may have a normal range QTc. The HRS-EHRA guidelines on genetic screening for long QT syndrome are as follows. They give a Class 1 recommendation for comprehensive or long QT syndrome types 1 to 3 target genetic testing, meaning KCNQ1, KCNH2, SCN5A, for patients with a strong clinical suspicion for long QT syndrome and QT prolongation. They give a Class 1 recommendation for comprehensive or long QT syndrome type 1 to 3 targeted genetic testing for asymptomatic adult patients who have a QTc of more than 500 milliseconds in the absence of other clinical conditions that might prolong the QT interval, such as electrolyte abnormalities, hypertrophy, or bundle branch block. They give a Class 1 recommendation for mutation-specific genetic testing for first-degree relatives of individuals with long QT syndrome and an identified causative mutation. Finally, they give a Class 2B recommendation for comprehensive or long QT syndrome types 1 to 3 targeted long QT syndrome genetic testing for any asymptomatic patient with otherwise idiopathic QTc values of more than 480 milliseconds on serial 12-lead ECGs. Let's move on to the management. If long QT syndrome is diagnosed, a beta blocker, such as nadolol, should be initiated to reduce heart rate. A beta blocker works best in long QT syndrome type 1, more so than type 2, more so than type 3. So, long QT syndrome type 3 tends to need to move to add mexiletine on top of nadolol sooner. Ciprofloxacin should definitely be avoided in patients with long QT syndrome since ciprofloxacin will worsen QT. Cardiac sympathetic denervation is used for CPVT syndrome and certain long QT syndromes. So what do the guidelines say about long QT syndrome? According to the 2017 AHA-ACC-HRS guideline for management of ventricular arrhythmias and prevention of sudden cardiac death, in patients with long QT syndrome with a resting QTc greater than 470 milliseconds, a beta blocker is recommended. That's a class 1 recommendation. So that's the nadolol we talked about. In asymptomatic patients with long QT syndrome and a resting QTc less than 470 milliseconds, chronic therapy with a beta blocker is reasonable, class 2A, so slightly weaker recommendation. In high-risk patients with symptomatic long QT syndrome in whom a beta blocker is ineffective or not tolerated, intensification of therapy with additional medications guided by consideration of the particular long QT syndrome type, left cardiac sympathetic denervation, and/or an ICD is recommended. That's class 1. In asymptomatic patients with long QT syndrome and a resting QTc greater than 500 milliseconds while receiving a beta blocker, intensification of therapy with medications guided by consideration of the particular long QT syndrome type, left cardiac sympathetic denervation or an ICD may be considered, class 2B. Lastly, they say, in patients with long QT syndrome and recurrent appropriate ICD shocks despite maximum tolerated doses of a beta blocker, intensification of medical therapy with additional medications or left cardiac sympathetic denervation is recommended, class 1. How about athletes? Can athletes with long QT syndrome participate in competitive sports? According to the AHA-ACC 2015 Scientific Statement on Eligibility and Disqualification Recommendations for Competitive Athletes with Cardiovascular Abnormalities, it is recommended that symptomatic athletes with any suspected or diagnosed cardiac channelopathy be restricted from all competitive sports until a comprehensive evaluation has been completed, the athlete and his or her family are well informed, a treatment program has been implemented, and the athlete has been asymptomatic on therapy for 3 months. That's a class 1 recommendation. For an athlete with either symptomatic long QT syndrome or electrocardiographically manifest long QT syndrome, i.e. QTc more than 470 milliseconds in males and more than 480 milliseconds in females, competitive sports participation, except competitive swimming in a previously symptomatic long QT1 host, may be considered after institution of treatment and appropriate precautionary measures, assuming the athlete has been asymptomatic on treatment for at least 3 months. That's a class 2B recommendation. That's what I have for the long QT syndromes. So now let's talk about acquired long QT. Please remember, it's all the hypos that cause QT prolongation. Hypokalemia causes QT prolongation, hypocalcemia causes QT prolongation, and hypomagnesemia causes QT prolongation. What other effects of all the electrolytes? In hyperkalemia, you're going to see peak T waves leading to loss of P waves, leading to increased PR interval, leading to widening of the QRS complex, not QT prolongation. Again, hyperkalemia does not have QT prolongation, only the hypos do, leading to sine wave pattern, leading to VFib or PEA. You can remember this by remembering that hyperkalemia has spreading out of everything. Q waves, PR interval, QRS complex, except the QT interval, since QT prolongation can be remembered as exclusively a hypo phenomenon. Then for hypokalemia, you'll have flattened T waves, SC depression, U waves, and QT prolongation. You'll have ventricular ectopy, meaning PVCs, VTAC or VFib, and eventually this will lead to torsade de pointes. How about hypercalcemia? That one is exclusively QT shortening, whereas hypocalcemia is QT prolongation. Hypomagnesemia will have QT prolongation due to QU prolongation and polymorphic VT. What are U waves? U waves are a classic sign of hypokalemia, along with flattened T waves, SC depression, and QT prolongation. A prominent U wave is a U wave that is at least 1.5 millimeters tall, or at least 1/10 the height of the T wave that's beside it. U waves, other than hypokalemia, can also occur from bradycardia, especially in trained athletes with high vagal tone, amiodarone, digoxin, or quinidine, LV hypertrophy, RV hypertrophy in leads V4 to V6, or hypomagnesemia. These are the situations that can cause U waves. Now back to acquired long QT. The VT that is caused by hypomagnesemia is going to be polymorphic, not monomorphic. Torsade de pointe in patients with acquired long QT syndrome is most commonly precipitated by premature ventricular beats followed by a compensatory pause, a short long R intervals that initiates the cycle of VT. Torsade de pointe can also be provoked by bradyarrhythmias. Sinus bradycardia are frequent pauses. That is referred to pause-dependent long QT syndrome. Other than medications, hypomagnesemia, hypokalemia, and hypocalcemia, acquired long QT syndrome can also be from hypothermia, HIV infection, SSRI, and hypothyroidism. Medications that prolong QT interval other than antiemetics, antipsychotics, fluoroquinolones, and macrolides are TCAs, SSRIs such as citalopram, ranolazine, hydrochloroquine, amiodarone, sotalol, and flecainide. These are some of the medications that prolong QT interval. There's a much longer list you can look up on the website online. The risk of torsade de pointe with sotalol is less than 2%, but it is higher if there is bradycardia, female sex, pre-existing QT prolongation, history of heart failure, history of VT VFib, or hypokalemia. Now let's end with a short section on short QT syndrome. Short QT syndrome is much rarer than long QT syndrome. It is an autosomal dominant inherited channelopathy that affects the potassium channels, leading to abnormally shortened ventricular repolarization. The hallmark finding of short QT syndrome is a QTc interval less than 330 milliseconds in men, less than 340 milliseconds in women. A QTc between 330 and 360 may be considered suspicious also, especially if there is family history of arrhythmias or the patient has symptoms. Other than the QTc being less than 330 or 340 milliseconds, ECG of short QT syndrome will also show tall peak T waves in some leads, absent or very short ST segments, and sometimes atrial fibrillation may be present. The mechanism of short QT syndrome is genetic mutations in potassium channels such as KCNH2, KCNQ1, and KCNJ2, resulting in increased potassium currents, leading to accelerated repolarization of the ventricles. This shortened repolarization period increases susceptibility to reentrant arrhythmias, which can lead to VFib, syncope, and sudden cardiac death. If any of these occur, you can place an ICD. What do the 2017 VT guidelines say about short QT syndrome? In asymptomatic patients with a short QTc interval, observation without treatment is recommended. That's a class 1 recommendation. In patients with short QT syndrome who have a cardiac arrest or sustained ventricular arrhythmia, an ICD is recommended if meaningful survival greater than 1 year is expected, class 1. In patients with short QT syndrome and recurrent sustained ventricular arrhythmia, treatment with quinidine can be useful, class 2A. This is because quinidine is a class 1A drug that can prolong the QT interval. In patients with short QT syndrome and VT VFib storm, isoproterenol infusion can be effective, class 2A. In patients with short QT syndrome, genetic testing may be considered to facilitate screening of first-degree relatives, class 2B. Congratulations, we have covered not just short QT syndrome, but long QT syndrome, including definitions, QTc formulas, the different types of QT syndrome 1, 2, and 3, and management of long QT syndromes, as well as acquired long QT.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.